think that's it for the housekeeping. So before we ask Ghazala to take the stage, just a few things to mention about her. I've known Ghazala for a while now because she has been co-supervising Olivia Joseph's PhD alongside myself and Beth, and we've learned so much from her in the course of that time that we were really delighted when she accepted the invitation to come and talk today. Ghazala is Professor of Health Equity, and she has a very strong focus on health and social inequalities across all of the work that she does. Particularly her research covers disadvantaged ethnic and faith communities, women and people with learning disabilities. And Ghazala is particularly interested in research on interventions that reduce health inequalities. Her research has been published in case studies of good practice by the Chief Medical Officer and the Economic and Social Research Council. And she's founder of and chair of the Multidisciplinary Inequalities Research Network, and has really led on work to highlight key research priorities in this field. So we're absolutely delighted and very lucky to have Ghazala with us today. And I will hand over to her to introduce her talk, anything else she wants to say about herself, and to deliver the seminar. Thank you, Ghazala.
Thank you very much. It's my pleasure to be here. I'll just share my slides if that's okay. I'm not sure if I can actually, so I can't see the chat as we're going through, but if you just put your any questions that you've got in the chat, then hopefully I'll be able to answer them at the end. I can't see the chat box while I'm doing slideshow, but hopefully you can all see that. Yeah?
We can, thanks, Ghazala.
Yeah, great.
Oh,
okay,
sorry, we can't see your presentation yet. We can see the chat, we
yeah.
can't see the presentation yet, sorry. Or I can't at least.
Oh yeah,
no.
I went to slideshow before I put the presentation.
I think this is doing something.
Is that okay now? Oh, and the chat box has come up, which is great.
Yeah, we can see your notes as well there, Ghazala. I don't know if it needs to be on a different setting.
Oh, okay, let me try stop sharing again. Right, it should have been on slideshow there. Let's try again.
Yes, if you go into slideshow there, this is looking great, Ghazala. Thank you.
Okay.
Perfect. Thanks very much.
Great. All right, thank you. And I can see my chat box, which is great. So let me just put my phone on silent as well. Which I should have done before, sorry. It's confusing to do it. All right, yes, sorry. Okay, so yeah, I'm Professor of Health Equity and Inclusion at the University of Leeds, and what I'm trying to do today really is focus on the issue of patient safety, although that's not my focus particularly in terms of my research, but many of the health inequities that I've looked at in terms of my research do bring up issues of patient safety. And as you'll see, they're linked to the issue of social inclusion and exclusion. So just to give you a bit of an overview, I'm going to be looking at how social exclusion is related to the topic of patient safety and inequities, and what social inclusion in terms of patient safety might look like. So we'll be looking at how exclusion is created and maintained within healthcare settings, and what inclusive healthcare services need to take account of really in terms of those dynamics. So I'm sure you'll all know a lot more about the definitions of patient safety than I do, but they focus on, as this WHO action plan mentions, cultures, processes and procedures that aim to lower the risks, reduce the occurrence of avoidable harm and make errors less likely, and reduce the impact of harm when it does occur. And in other definitions, minimizing harm and error experienced by patients while receiving healthcare. So looking at things like reducing the occurrence of post-operative complications and how they might disproportionately affect particular populations. Medication errors, things that should never happen, like doing surgery on the wrong site of the body, delays in diagnosis and the response to a diagnosis, things like hospital-acquired infection, and also it incorporates reducing psychological harm that might happen as a result of excessive restraint or inadequate treatment of pain and negative patient experiences. And that's not a comprehensive list, obviously, but some of the key issues that overlap with the research that I've looked at. Slides will be shared afterwards, yeah. Okay, so in terms of excluded groups, socially excluded groups, what we know already is that there is evidence of poorer quality healthcare for people from groups that experience disadvantage. So that can include minority ethnic patients who we know have higher rates of adverse drug events, more likely to have pressure ulcers, more likely to develop sepsis during the operation period than white patients at the same hospital. And then patients from deprived backgrounds or people with a learning disability are more likely to experience delayed diagnosis and intervention. And in some of the research that I've looked at in terms of maternity services, again, delays in terms of recognizing issues, the referring, and then actually treating issues that might come up. Okay, so just look at a couple of other concepts alongside patient safety. I've mentioned social exclusion. And again, social exclusion is embedded in processes that happen within formal institutions, including healthcare organizations. And my own research has looked at public services like healthcare, but also determinants of health. So within education, within areas to do with housing and local and national government. And these processes they're the mechanism through which disadvantage is created and through which it operates. And if we want to address them, then we have to think about improving the terms of participation in society for groups that experience disadvantage. That means looking at the opportunities that are available to them and increasing their access to resources, their voice in decision-making, and respect for their rights. And we need to think about these things at the level of the macro level, which you could understand as a societal and policy level, at the meso or institutional level, and at the micro or community and individual level. Because if we want to really reduce social exclusion, we have to address those drivers simultaneously because they operate simultaneously. So often we find that interventions are targeted at the individual or the community, but actually they're not addressing things that might be happening within institutions and at the policy and societal level that undermine what you might be doing at the individual and community level. So as part of one study that I did, we did a systematic review focused on the question of how public services, including healthcare, could become more inclusive of ethnic and religious minorities. And this looked at the global literature. We looked at review studies because there was obviously a lot of literature around. So we just looked at reviews. And we identified 56 studies that were published. The review was published by the UN Research Institute for Social Development. And from this, we developed a model for how social exclusion operates. As I mentioned, at the macro or socioeconomic and political level, there is competition for work and other resources. And there are power imbalances between groups that mean that some groups are more able to access those resources than others. And the use of racism, stereotypes, and the promotion of misconceptions help those power imbalances remain as they are, and helps some groups maintain their advantage at the expense of others. And these kind of dynamics also affect what happens at the meso institutional level. So there can be a failure to recognize the needs of those groups, or even to recognize that they exist. So data collection might not even disaggregate data so that their needs are invisible within the system. They may also be invisible in terms of staffing, and there may be barriers to involvement of people within decision-making within the institutions. And all this leads to inequities in service provision and service outcomes. And at the micro and individual level, individual and community level, we can see the outcomes are very much intertwined with these kind of dynamics. So it's kind of like a vicious circle, really. We have power imbalances to begin with, which lead to results and consequences for individuals and communities related to poverty, unemployment, poorer health, lower health literacy. If you're not doing very well within the education system, you'll probably have lower health literacy, lower influence to people within positions of influence. So social and cultural capital is also diminished, and then lower understanding of the system and lower use of the system because of mistrust and fear through negative experiences or through knowing about the negative experiences of others. So social exclusion in public services is as a result of constrained access in terms of how services are structured, where they're located, or the terms on which they're provided. So lower rates of referral, for example, if people are not diagnosed quickly or referred for specialist help, or there are culturally inappropriate materials, will lead to lower awareness or use of services. And then even when people do use services, they may receive poorer quality, earlier discharge, less follow-up. From the reviews that we did, we noticed that this was a common theme within studies, and lower satisfaction with services is linked to this poorer quality of services that are received. And then a lack of what was termed cultural safety, so stressful interactions between practitioners and people using services, having a negative impact on people's idea of what they were able to achieve and their confidence in using services. And in another study in which I looked across different socially excluded groups, not just ethnic and religious minorities, but also younger people, we looked at gender differences, and we looked at people from rural areas as well. We found that there were common themes in terms of their experiences. So they were often invisible in terms of service planning and delivery, or they had a heightened visibility in which they were targeted for discrimination. And all this could lead to exclusion from opportunities and resources. And the way we described all the different examples of how that happened was that this was really a spectrum where people could just be neglected and not even recognized as having needs, or else they could be subjected to restrictions and discriminatory practice. And all this kind of spectrum we described as structural violence, which is a concept within the literature on social exclusion. And that's linked to poorer life chances, physical and mental illnesses, physical abuse, and even death. So all these kind of outcomes for communities are linked to this concept of social exclusion. So within this review, we also looked at how inclusion could be achieved in terms of the various barriers and dynamics that I've just described. So at the macro level, there was evidence that providing financial assistance or other incentives could help to in this competition for resources, where some groups had more resources than others. Providing financial input to those with less resources could be really helpful. And then participatory decision-making could help correct power imbalances, where people from excluded groups were deliberately targeted to inform decision-making. And then reforming systems where the social norms that had become to seem, had come to be seen as acceptable, but were actually based on racism and stereotypes and misconceptions about communities, that those norms were actually reformed within the system. At the institutional level, revising policies in similar ways, trying to get rid of policies that were actually discriminatory, increasing representation amongst staff so that within particular services they represented, service staff represented the communities that they were actually there to serve, and reducing discretion where that could lead to discriminatory behaviour. So best practice protocols could be very helpful in terms of standardising care and making it consistent across different groups. And then at the individual and community level, where most interventions were actually targeted, behaviour change training could be helpful if it wasn't done on its own. I think if it's just done on its own to try and fit the community or the individual to the way that systems work, then it was found to not have any effect. Health promotion within communities was also important, and skills development so that they could negotiate the health systems that they were engaging with. And all this actually really mirrors, so this review that we did really mirrors what we find in the patient safety literature and the kind of international work that has been done around this. So the WHO Action Plan describes high reliability organizations as being very person-centered, participatory, having inclusive service designs, and understanding these multi-level dynamics that I've described, that individuals within systems are influenced by the environment in which they operate, by the social context, and by the organizational culture, and by national policies. And this action plan points to the need to engage and empower patients, families, and communities as the cornerstone of patient safety, and that equity and inclusiveness in healthcare is part of a safe organization or an effective kind of patient safety plan. And then it also refers to this idea of transformational change, that we can't just tinker at the edges. We really have to get to the core of what it is that is stopping people from receiving the best outcomes or similar outcomes across groups. And then I've looked at one particular area. This is not my research, but this is in terms of the evidence that's available. If we look at one area of surgery, again, we're finding that effective interventions to to increase patient safety are again focused on the kind of things that I've been talking about: community engagement, involving community members to help foster ideas of connectedness, feelings of belonging within the service, and trust in services, which have historically been lacking because of medical misconduct and discrimination that people have experienced. Again, this idea of best practice protocols are associated with reduced ethnic inequities in post-operative surgery. And then standardized treatment pathways, so reducing this variability where discretion can be used in a discriminatory way. And the use of care coordination, navigators, and feedback systems can help people from minority ethnic communities or racialized communities to receive better outcomes from care. On the issue of representation, again, within just looking at this topic of surgery, we find that often people are not part of surgical teams because of inequities in education. So if there are inequities in education, that means that there are less people coming through who have the capacity to be involved in surgical training. So those kind of inequities are barriers to becoming surgeons or leaders within healthcare systems. So again, the financial costs, as I've mentioned, need to be addressed if we're trying to reduce those inequities. And that people who are concentrated in low performing middle and high schools because of their ethnic background need to be, given the extra boost that will help them achieve the grades that they might need in order to enter this profession. And then mentorship, even when people do get into higher education, mentorship can often be discretionary. Again, who actually gets offered mentorship? So more formal systems where those are offered, more equitably. And what the literature shows is that if there is low diversity amongst the surgery workforce, then that's detrimental to the effectiveness of teams, to patient-provider communication, to access in vulnerable communities, and to identify the needs of different patient populations. All of those are the consequences of social exclusion within institutions. So the key lesson that comes out of that kind of literature is increasing diversity amongst the physician workforce would improve not just healthcare access, but outcomes and patient satisfaction amongst these racialized communities. And I wanted to reference Livy's work within this, although it's not related to surgery, but this is not just about patient-focused safety. Actually, the safety of staff can also be affected, and where staff are treated in ways that are discriminatory within staff groups, so staff from racially minoritized groups who are subject to incivility and discriminatory practice. The link has been found within Olivia's work from the evidence that's available to adverse effects on performance and patient care processes. So these are all relevant to those kind of processes as well. So in terms of what can be done about these things, one way forward in terms of representation, we've had various reviews about, again, this focuses on racialized communities, but given my other work in other areas and with other groups, we can see that many of these approaches would work across socially excluded groups. So having representation on interview panels, trying to get a diverse workforce means that you should have a diverse interview panel, because again, people often appoint within the frameworks that they understand, and they appoint in their own image. So trying to get away from that, just as we do with gender, that we make sure that there are mixed gender panels for interviews, we should be doing that for other excluded groups as well. And then making sure that diversity is promoted, not just within the institution, but through contracts and supply chains, stopping processes that actually give advantage to certain groups. So unpaid or unadvertised internships means that those already connected to the system, those who can afford to work for free, are more likely to take up those experiences that will really add a lot to their CV and make them look much more appointable in the future. And then clear information about what a successful career path looks like. So I'm just picking out various things here. There's a whole range of strategies that are mentioned. And as I've said, mentoring and sponsorship can also be very helpful. So then going back to the review that I mentioned, helpful approaches spanned a whole range of issues. First of all, to just recognizing that any intervention needs to take account of the contextual aspects of inequality, that power and privilege exist, that racism can be internalized and not necessarily just experienced externally, that people often feel have low esteem and feel less capacity to actually, and less confidence to apply for work or to access certain opportunities. Education, health and social outcomes are all linked, and early childhood experience is really important in terms of reducing disadvantage. And then these multiple strategies that I've mentioned are required for system reform. We need tailored solutions that incorporate the views of disadvantaged groups, and structured communication processes that allow for intergroup dialogue, so that people can have a voice without feeling that they have to really change their complete way of thinking and articulating themselves in order to have that voice. So partnerships are a key point of this. And in terms of interventions, staff ownership and readiness to change is really important too. Again, this comes out in the area of surgery that I mentioned, where multi-level interventions, again, were pointed out as being most effective, combining several system interventions significantly reduced ethnic inequities in surgery, and then having various kind of multi-level kind of actors who could feed into the intervention. And then I just wanted to mention a piece of research in which I've been involved, which has really is an example of this kind of multi-level intervention in terms of healthcare to treat mental health, so in the area of depression. And this is something that I've been working on for a number of years now, where we've tried to identify what the access and engagement barriers are to begin with, and looking at why people from Muslim backgrounds don't access therapy services, and when they do, why they get poorer outcomes. And what we've found from the existing evidence in this area is that in terms of cultural attitudes towards religion in general, and then towards Islam in particular, these are a huge barrier for people from Muslim backgrounds to whom religion might be a very important aspect of their identity. So within the European context, we've had this whole separation of religion out from public life, which doesn't really reflect the way that Muslims think about their religion. Religion influences every aspect of their life. Within services, we have an overrepresentation of people without religious beliefs, which means that services operate in particular ways, and there may be hostility or resistance to incorporating attention to religion. practitioners aren't trained in terms of engaging with religious identity, even though it may be a core value for people that they're interacting with. And so there's the potential within these services to just replicate the social exclusion that people experience outside of services. And standard treatment models can undermine or threaten the way that people may actually cope with difficulties in their life, with depression and other kinds of issues. So religious coping, which is a positive thing, it can actually help people in terms of resilience and feeling hopeful, and recovery from difficult life events, can be undermined within standard treatment models. And this itself causes mistrust within Muslim communities and can also cause fear through policies such as the Prevent policy, which actually in an Islamophobic environment as we live in, where Islamophobia is a key dynamic that affects Muslims using healthcare, they can feel afraid to use services because they may worry that they'll be referred to Prevent for anything they might say. So in developing this intervention that we looked at, we started off throughout we've used the MRC framework for complex interventions, and we started off looking at systematic review of literature. We interviewed people with expertise in the areas that we were looking at, and we identified a culturally adapted intervention that we then further adapted for this community. We then went on to pilot that and published the findings from the pilot. We found it was feasible within the UK context. We've also done a feasibility study for Turkey. And we went on to do 2 RCTs. So we've evaluated the effectiveness of this approach in Pakistan and in the UK. And we're now working on a study to look at implementation at scale, what kind of things might help this to be implemented and embedded within services and to produce implementation guidance. So just to say a little bit about the Bradford trial that we did, the UK one, we trained therapists in the NHS and in 3 voluntary sector organisations where the ability to engage with Muslim communities is probably more developed. And we compared that group to non-trained therapists who were delivering either CBT in primary care services or social interventions in the voluntary sector. And they were also in the intervention on delivering BAM, which is the therapy that was designed, adapted for the needs of Muslims. And what we found was that there were statistically better outcomes within the intervention group compared to treatment as usual. And this was explained by improved retention. It's not that CBT isn't effective. People were improving at a similar rate within the 2 groups with CBT and BAM, the intervention. But what was happening was that people were dropping out from the treatment as usual much faster than they were from BAM. So they were typically attending 3 more sessions, so more engaged, more motivated to engage with the BAM than they were with the treatment as usual. And that is in line with existing evidence. We know that there are better outcomes for culturally adapted depression therapies than there are for standard treatments. And just to give you a look at the PHQ-9 trajectory. So PHQ-9 is the measure that we use for depression levels. And on the first graph there is the intervention. You can see that people were engaging for a lot longer, whereas dropping out much more within the treatment as usual on the right. And the red lines are primary care, the blue lines are the voluntary sector. They're particularly marked within the voluntary sector, but very much so even within the primary care talking therapies too. So what that intervention was really showing is that we have current evidence that show that services are replicating social exclusion. There's poor access and engagement. There's a lack of early intervention, low recovery, low trust in services. Within services, people, that we interviewed talked about being stereotyped, experiencing Islamophobia. They referenced the use of Prevent policy that made them fearful to use services and gave instances that they'd heard of, not necessarily even directly experienced, but even hearing about an experience of somebody being criminalized because of use of mental health services puts fear into people using those services. And if we remember that Muslim communities in the UK are already overrepresented in terms of their higher unemployment levels, lower education levels, poorer housing, lots of environmental stresses. And then to have that replicated within services is just adds to the stresses that they're facing and reduces the amount of support that they can get. And within services, we're getting no engagement with the value frameworks of Muslims themselves. The kind of treatment models were not taking account of the fact that there is a type of knowledge within Muslim communities about how to get better, that they might need support to put into operation. And there are resources within Muslim communities that can be used to support people to recover from depression that were not being used. So with this approach, what we were trying to do is really transform services to be more socially inclusive. And that was achieved through better engagement with the people using services, but also within the service itself, we were promoting reflexive attitudes towards religion and towards Islam amongst practitioners and, at the kind of decision-making level within the service. This approach helped people avoid stereotyping and prejudice, and even at the wider service level, promoted the legitimacy of Islam as a value framework. So that is really a strong challenge to Islamophobia. And practitioners were targeting all the other adverse social circumstances that people might be experiencing through the therapy that they were delivering. And they were collaborating with people within communities who had relevant expertise. So there was much more engagement at the individual, community, system and policy making level. So I think, what is really coming out of all this evidence that I've presented to you is that, in terms of health system design, and in fact, in terms of research itself, we need to have equitable ways of engaging with communities that are inclusive and reflexive, that will actually model inclusion. So in order to actually carry out this research, the research team has to model the inclusion that we want systems to actually put into practice as well. That means privileging excluded voices, analysing the research context, decolonizing knowledge creation, to be critical about the knowledge that's there, and to recognise the context in which knowledge is created, and to have linguistically and culturally skilled teams, and to co-produce the interventions that we come up with. So that's the end of my thing. I've just heard the knock at the door, so I'm just going to go and answer that. I'll be back in a minute.
That was perfect timing, wasn't it? While Ghazala's answering the door, perhaps if anybody does have any questions, they could pop them in the chat. I've seen a couple of brilliant questions coming up there, which I'll raise with Ghazala when she returns. But if anybody else wants to ask a question, please do think about it now and jot it down. Be prepared to put your hand up or put it in the chat, please.
Thank you. All right, yeah, while I was presenting, I didn't actually look at the slides very much, but thank you for putting those in.
Thank you so much, Ghazala, for a really fascinating talk, and one that's, I know, made us all sit up and think and question the things that we do without thinking sometimes. So that's really important. You've got a few brilliant questions, so I am going to just kick off, if you wouldn't mind, by asking Will. And Will's got a role in teaching undergraduate medical students, and so I think he'd like to ask you about that to start with, if that's okay.
Sure.
Hi, Ghazala, yeah, that was fascinating and quite eye-opening in some of the findings and things that you presented. But I just thought, like I said, I work in a medical school, and I was just interested if you had any experience or reflections on how these issues are tackled within, or not tackled within undergraduate medical education, both in terms of the curriculum for the students and how we teach them, but also the design of the delivery of teaching for them, if that makes sense.
Yeah, so I can talk about the experience here at Leeds. We have a whole stream of work around decolonising the curriculum, which is one of the ways in which these issues are being addressed. And there are a series of questions that are put to module leads, for example, or programme leads around, are the is the evidence that you're putting forward in your teaching, for example, is it very focused on Western kind of authors and Western conceptualizations of what's happening internationally and globally? Or are you representing the voices and authors from the global South, low middle income contexts, and representing what they say just as valid? So it's not very heavily orientated towards those contexts in which there's more resources maybe for research and evidence production. So are you looking at that? Are you looking at the findings from the global South as though they're generalizable globally, or are you saying that they're just specific for that context? Because again, this is something that we do with the global, with literature from the global North. We generalize it to the whole world, but we don't necessarily do that for evidence from low and middle income context. We say, oh, that's specific to that particular context, but actually there may be knowledge production there that is globally relevant. So those kind of questions in terms of who is represented, in terms of the evidence that's presented, taking a critical kind of approach to the evidence. And then in terms of who's actually teaching on the, in medical schools, who is actually teaching? Are you representing the student body? Are you recruiting a student body that is reflective of the, if it's universities tend to take a national kind of, a national body of students. So are you reflecting the national student body within your student cohorts, and is that reflected within your staffing? These kind of issues are coming up at Leeds. I can't say that we've got the answers here, but those are the kind of things that I think it's worth looking at.
Thank you, Ghazala. I've got two questions in the chat that relate very specifically to your project around mental health and culturally adapted interventions and delivery. The first by Labena. So Labena, do you want to ask a question of Ghazala?
Yeah, hi, thank you. Can you hear me?
I can.
Oh, so it was a really interesting presentation. I forgot my question. Let's bring it up. Yes, I was just interested, when you said that the practitioners who are delivering the intervention, that they're, I don't know if my camera's on, it is on now, the practitioners who are delivering the intervention, they are bringing Islam into it, or they might tailor the intervention, the therapy to the person's religious beliefs. So I was just wondering, at what point would the therapist think, would they be a point that they think that, okay, I need to introduce maybe aspects of the religion into the therapy, or would this question be asked at baseline, or is it needs assessed? And I was just wondering how would you go about?
Yeah, so that's a really important question, and what is best practice in terms of addressing somebody's religious identity? Do you even know that they want you to address their religious identity and take it into account? So these are all things that we were able to look at in terms of the evidence base and interviews right at the beginning of our project. So we identified a whole spectrum of practice where some people would say, no, you can't raise it unless the patient raises it themselves. Others would say, no, if I raise it, I'll get sacked. And then others were saying, you have to make space for this, because if you don't make space for it, it may be important to the person with depression, but they won't raise it because you haven't made space, and they may wonder what you're thinking about their religion. They may actually be fearful of raising it, or worry about being discriminated against if they do. So what we came up with was a tool that it's called a values assessment tool, and it has various areas of life on it, like family, work, religion, and spirituality being one of these areas. Because again, what came up with in our discussions with therapists was that if you simply ask somebody from a Muslim background, is religion important to you? It could be quite difficult for them to say no, even if it's not really very important, just because they might feel, they're expected to say yes. So this values assessment tool is used right at the beginning of therapy to identify which areas of life are very important to that person. And within this therapy, the whole principle of behavioral activation, which is a well-established therapy with an equivalent evidence base to CBT, is to line your behaviors with your values. So set goals, activation goals that are in line with your values. And that's why we selected it, because it gave us a kind of a way in to introduce religious identity. So it's very much client-led, service user-led in terms of how much religion is identified as an important value, and then how much they want it to be paid attention to in the therapy itself. So we created a client self-help booklet that includes religious teachings that people can draw on. They parallel what the therapist will be trying to achieve from a therapeutic point of view. So it's a resource for positive religious coping, but very much up to the service user, whether they want to pay that attention. And sometimes they can be quite religious and say, no, I don't want to do that. I'm already doing that at home. I don't want to do that here. I want something different from here. So yeah, I think, you know, it's actually not a straightforward answer. You've got to get all the evidence together to actually be able to answer a question like that. And for the time that we've spent on developing this, I think we feel quite confident that we've got the best practice approach. And when we've tested that with therapists that we train, you know, they can see the benefit of it. I think it's often a comfort zone issue more than anything else.
Thank you, Ghazala, and for your question, Ladena. Jamila next, then we'll have Jane's question, because they're all again specific to the intervention, and then we'll come up and we've got Jenny and Alicia to ask questions as well. So Jamila, if you would like to go next, please.
Yeah, thank you. Such a brilliant presentation. I learned it stimulated so many thoughts and questions, but I guess, and I think you've kind of answered it a bit. I was a bit worried about, sorry, I should introduce myself. I'm a palliative care doctor working at the Trust. We also do research around inequalities at the end of life. And obviously Islam is something that is part and parcel of our day-to-day clinical experience. And I guess one of the things, there's such diversity within how people practice Islam, say within Bradford context where we work, and sometimes coming at it in a certain way can exclude certain people, kind of like, oh gosh, actually I don't want to do that. But also from a clinical perspective, for people who aren't Muslims or can't be steeped in that level of knowledge or cultural kind of understanding, it can result in stereotyping. And again, some of our research has shown that results in really bad outcomes and bad experiences and people not getting access to care. So I was just really interested in what you said, it promoted reflexive attitudes towards religion, and I just wondered if you could expand on that a little bit.
So we give training before people deliver this approach, and we get them to think about their attitudes towards religion in general, their own attitudes towards religion and their own sort of identity in terms of religion and where they stand. And their ideas about Muslims, we kind of get them to think about that. So we do various reflexive exercises in the training that get them thinking about how their own attitudes towards religious identity and towards Muslim identity in particular might impact on the person that they're giving, you know, depression therapy, you know, working with on depression. So that those kind of reflexive attitudes are really important, because it gets people to recognize that even if they don't want to have a particular thought when they see something, so somebody might come in dressed in a particular way, part of the training is we show them images and ask them to just write down the first thought that comes into their mind. And often they don't want to have that thought, but we're surrounded by those images and those narratives, and it's, even if you don't want to, you sometimes have that thought. So just being aware of it to begin with is really important in terms of being able to put that to one side and recognize that you've got that thought and that it could potentially impact on the person in front of you. So it's really important that people are aware of that. And in terms of their own knowledge of Islam, we make it very clear we don't expect anybody to be experts, religious experts, whether they're Muslim or not, because a lot of Muslim therapists also feel like, I don't know that much about, you know, about Islam. So the self-help booklet that we've developed, we didn't originally intend to develop this, but we saw a resource that was developed in Sheffield for people from the Somali community, and it was for psychosis. And one of the staff members said, I find this so empowering because it helps me to understand where my patients are coming from. So the resource that we developed kind of followed what the therapist would want to get out of therapy, but using religious teachings to reinforce that. So, for example, the therapist would want the person to play a part in getting better and not to just be fatalistic about it. So we had a religious teaching which is called "Tie Your Camel," and which there's a saying of the Prophet Muhammad, peace be upon him, that he saw a Bedouin letting his camel just wander around, and he said, "Why don't you tie your camel?" And he said, I trust in Allah. And he said, "Tie your camel, then trust in Allah." So basically, do your part, and then you can understand both things at the same time, that you have got a part to play and you rely on God at the same time. So that can be a turning point for many people, where they sort of realize. So those kind of teachings are helpful to the patient, but also very helpful to the therapist to understand that this might reinforce what I'm trying to get across here, where I can see that's a sticking, a kind of a place where people have got stuck. It may be that this teaching might resonate with them, or I can ask them to pick on something in the booklet that does resonate with them, and we can maybe use that in the therapy to help them just turn that corner of not being stuck anymore.
Great, thank you.
Okay, thank you so much. So we're moving on now to Jenny. Would you like to ask your question?
Ghazala, thank you for that. Really interesting. So I suppose mine might be a bit out of the scope, but and I know there's a lot of work to be done, but I've been reading articles recently just in the national newspapers that I think miss some very important nuance, or they're actually quite damaging to the contribution of everyday people's thoughts in terms of racial stereotypes. And I just wondered, such good work going on here. And, within patient safety research, we're delving into safety inequities and solutions and that sort of thing. But whether it's our job or not, I don't know. But there seems to be no counter narrative in mainstream media to these damaging conversations. And I just wonder as researchers whether we should be, we engage with policy, all the rest of it, but whether the media is a missing link in this, because they have, they've got such a wide readership and they can just continue to reinforce things. And there are some very positive things that you're saying here. So yeah, I don't know at what point we engage the media in some of these positive spins.
Yeah, so when we'd finished the pilot study for this, oh, sorry, you're still there. When we finished the pilot study, I was invited to a roundtable with the BBC on inequalities and representation and things like that, and I kind of gave them a bit of a telling off for the way that they always focused on bad news stories and things. And then somebody got in touch with me later and said, we've looked at your research, would you like to do a piece for the BBC? And I was actually terrified. I was terrified that of how they'd portray it and the response that might come as a result. But I did go ahead with it. We had a voluntary sector organisation that was delivering it in Leeds at the time. And they did a really great piece on it. The BBC did do a really good piece. It's been translated into different languages on their world service. And, they did a great piece on it. But I think that whole dynamic just sort of portrays how kind of unsafe the media can be. That often, because we see all these negative stories about excluded communities, we can't be sure that what we put forward in terms of our research will be portrayed in a way that's actually helpful. When I did the pilot study in Bradford years ago, we actually had the Keighley MP get in touch with Bradford District Care Trust. I was heckled at conferences. This was about 10 years ago. The Keighley MP got in touch with the service and said, "Why are you spending money on this?" It was actually NIHR funded, but why are you spending money on this? It was just constantly, and things have changed, a lot in terms of services being much more confident to say that we need this. We can see from the figures that things are not working the way they should. But the mainstream media, I mean, you just have to look at the coverage of Israel and Gaza to see that they are not interested in doing anything more than really parroting the mainstream narratives. And this is always a risk. So I don't particularly reach out to the media as my first sort of port of call for dissemination. I think, in my view, if we can get public services to be more representative, that will have, and I suppose, you know, the media is, you wouldn't probably call it a public service, but I think the way we influence wider social attitudes is through public services. That is the mechanism. So while I wouldn't turn down a media opportunity, there's always that fear of how things will be portrayed and the negative kind of response that could come back. And the mainstream media in particular, I think in social media we have more of a chance, and I do constantly, you know, tweet about these things, but in mainstream media I think we've got less of a chance of fair representation. I don't think we should not engage, but you know, it's much harder to engage with them.
Thank you.
Thank you, Ghazala. Medina has said she's unfortunately had to witness you being heckled at a conference. I
think I became famous through that heckling. Actually, it was a good launch for the project. You know, it kind of demonstrated what we were up against.
not something I'm not sure it's something we train researchers for, is it, being heckled at conferences?
And I wasn't protected by the chair. I remember at the time it was a conference. The chair didn't actually stand up and stop it. So I had to get up and actually respond. And a lot of people, what's encouraging is that a lot of people came up to me afterwards and said that was outrageous, you know, what happened. I think it is a minority of people who have these very strong views, but they are very vocal often. And this was a very senior person who actually heckled me. They have a lot of influence a lot of the time, even in the NIHS study that got funded. It was funded at, it was an RF, Research for Patient Benefit study. So it was funded at local level. At national level, I had much less success in being able to get that kind of funding. And I heard from later from somebody who was on the panel that there was one person on the panel who was really hostile to the whole idea, not because of the science at all. It only got through because there was nothing wrong with the science, and the chair himself was Muslim, so he kind of, you know, challenged this hostility. But you can see where there's not that representation. You can see that people might not be able to get it through.
So we've got 2 or 3 minutes left. So I'm going to come to Alicia next for her question.
Hi, yes, thank you. And such a thought-provoking talk. Thank you so much. My question was really about the relationship between technology use and all the inequalities work that you're doing. Because I think, you know, certainly from a patient safety point of view, I think there's obviously a slight anxiety that we're baking in more issues along patients' journeys through services, but also we're not really surfacing and addressing some of the issues that are around technology use now in care. So it was just whether you think there's things that we could map across learning that we can embed in digital work that's done.
Yes, I've been part of a project that was to do with using an app to help with management of hematology conditions. And we set up a service user advisory group that was made up of people from groups that might be that might have problems with the, you know, digital technology. So older people from rural areas, minority ethnic communities in particular, people from deprived backgrounds. So things like just not knowing how things work, how the digital apps might work, not feeling confident with them, but also, you know, the expense that might be involved, you know, of having data, for example. So I think, you know, in terms of those kind of that kind of operation where you're using digital technology, I think it's really important to develop it in a way, or to adapt it in a way that is inclusive and to have choices, so that people are not obliged to use that as the only way that they can communicate, or that they can, you know, get access to the way that they're being managed. That there are choices. So you might have the majority of people managed in that way or communicated with in that way, but to recognize that not everybody is going to fit that model, and to have some ability to engage with people who don't have access to the digital intervention, or can't access it for whatever reason, so that it's not the only way that patients can communicate. I don't know if that answers your question.
To a degree, I guess. I think some of the other issues I've been mulling are really around when things fail, who people go to get help. You know, a lot of it's relying on people to enter their own data. So, you know, you may be required to read a lot, even on an app that's actually really unintelligible, often whatever language it's in. But you know, I think there are lots of issues around that, and that can add to somebody's risk profile, really, but without ever people realizing that or doing anything about it. So I suppose those were the sort of things that are going through my mind.
Well, there are definitely risks, aren't there? And this is really for whoever's developing that type of intervention or working with it to address, really. It's not the patient responsibility. It's got to be something for practitioners. So what I noticed in the development of this app that I was talking about is that practitioners didn't want two-way communication because they were worried they might miss something that the patient would say. And they were very clear about how they could cover their own risk of not responding, but not necessarily the risk for the patient. So I think, yeah, it's the responsibility of practitioners who are using this kind of technology to make sure that the risks are covered for the patients as well as for themselves.
Thank you so much. There are one or two more questions in the chat, Ghazala, but if you wouldn't mind, perhaps those two people contacting you separately after the meeting to ask anything that might be outstanding. And I just wanted to finish by saying thank you to everybody for coming along today and to hear that absolutely fantastic presentation by Ghazala that's definitely got us all thinking. And we'll go away and do some more. Thank you so much, Ghazala.
Thank you very much. Bye-bye.